All right, I think we'll get started. We have some great speakers after me, so if people are trickling in while I do the intro, I think that's fine. I want to welcome you all to the Integrated Health Campaigns and Immunization session. So I'm Karoline Tufte, Lien, and I'm one of the product managers for the DHIS2 software. So great to see so many in here already after the coffee break. And I also want to welcome all the online participants that are joining, either through the remote conference participation or through the Gavi-sponsored DHIS2 for Immunization webinar series that this session is also part of. So in this session, we will highlight a bit the recent work in the DHIS2 software and documentation to enhance DHIS2 for planning, monitoring, and evaluation of integrated health campaigns. Alongside these updates, we'll also have a presentation from UNICEF on monitoring, immunization, and catch-up campaign using DHIS2. Just moving to this. As well as a country case study on the impact of electronic immunization registries in Somalia, presented by HISP Tanzania. So we hope this session will really help you gain insights into some practical solutions, challenges, and lessons learned from these implementations, as well as how these new DHIS2 software features can contribute to meeting needs and gaps that we've seen in countries when they're implementing DHIS2 for campaigns. We'll do a little bit of questions after each presentation, and then we can see if we also have some time at the end. I know you all want to get to the networking and posters, etc. So I'm just going to move for now straight into talking about kind of the work we've been doing in the last 15 months to strengthen DHIS2 for the campaign use case. So the reason we've been working quite actively on the campaign use case for the last 15 months is that we've had a partnership with the Clinton Health Access Initiative funded by the Gates Foundation. So we're very grateful for their support. And within, we have a long list of activities within the collaboration, but some of the main things was that we really wanted to gather requirements and user stories for a variety of use cases of health campaigns. And as we do in the DHIS2 software, we conduct kind of functional analysis, again, look at user stories, create some initial designs, iterate on this. We wanted to do all of that for the campaign use cases and then scope them for the 42 roadmap. And then develop and release these identified but generic DHIS2 features, again, building on input that we collected. And in addition to this, also do our quality assurance, collaboration, usability testing, and early adopter user feedback with partners. In addition to this, we wanted to document and publish campaign guidance, again, around more configuration or workarounds or limitations within DHIS2. And last but not least, we wanted to also strengthen the kind of local applicability of DHIS2 for campaign use cases by supporting more the extend part of the platform with the developer community, custom app development, etc. So what the partners in the campaign space did was that they contributed to a feature backlog, which identified different gaps and additional enhancements and requests. And this collection then added as a pool of ideas to be reviewed when we did our functional design and release planning phase. And just to say that, with a packed roadmap as DHIS2 is, not everything in the future backlog was addressed in this one single release cycle, but they will remain, in our backlog for future prioritization. So feedback on, what is most helpful and high priority is always helpful. So just quickly, a bit on what we want to specifically do around documentation guidance is that we wanted to create a more generic toolkit. So we have one for strategic immunization activities, but we wanted to make it generic. We wanted to expand it. Again, adding documentation on different workarounds, but also the new features developed through the collaboration. wanted to gather more impact stories, especially around, for example, supervision use cases. And we're actually currently gathering more community input. We always want to hear from the community, again, on challenges, limitations of using DHIS2 for campaigns, use cases where DHIS2 still doesn't meet needs, other useful guidance, etc. So there's still time to fill in the survey here. It also includes link to the draft toolkit. So the link is there. We will, of course, put the slides on Drifta after this. So if you were in the What's New session earlier, you saw me and others present many of these features already, and you probably thought of how it could benefit implementations of your own. But we wanted to highlight a few of the ones that were really pushed through this campaign use case collaboration to show, how focusing on a specific use case can still lead to very generic and very helpful functionality that can help many use cases beyond that as well. So what I wanted to do is just highlight a few of the things that came out of this project and kind of give the original challenge from the campaign use case that then contributed to this feature. And in addition, you're going to get since you're special and you're in this session, you're going to get a sneak peek on some upcoming functionality. So again, I presented this earlier today, option set counts. This was one of the original challenges in that feature backlog that really came from a lot of partners in the campaign space. Again, because everyone uses option sets to record everything from travel history, team names, etc. And they couldn't disaggregate the data by this. They had to, again, configure a bunch of program indicators, or they could use event reports and event visualizer, which isn't ideally set up. So again, with this initial challenge, we decided to develop scope and really release the option set counts for the 42 release. Also, again, presented this one, which also, again, it's not that we haven't heard this request before, but it was part of the feature backlog for this project. It was really about there's currently no functional data dictionary app that allows the user to see all data types and description definitions, etc. Again, this is so important so that the user can really understand and interpret their data and know what they're looking at. This one always gets the applause. It's so nice. Then we have another one this was one of the first ones we started scoping out and taking a look at, because we know that a lot of implementations have been using DHIS2 Android as like the last mile, the campaign tool, and that often the coordinates weren't exactly accurate, or they weren't, when they were capturing it, etc. So we really wanted to give a lot more granularity. We wanted them to be able to set accuracy thresholds, to let you know when the connection wasn't good enough, etc., to really, get to improve the accuracy of coordinates. So this one is one I'm really excited to see how it can be used in upcoming campaigns in the field. And then a couple of sneak peeks. One of the ones was that often, for example, around malaria planning for campaigns, for example, it's based on source of infection. But when you register your case, your event organization unit might be where the case is notified, the facility level. And so when visualizing cases, there was no way of seeing the source of infection that was often a data element of type org unit. So this is kind of a sneak peek. This is almost done in development, and this is something that you will be able to do, map event based on also your data elements of org unit type. Another sneak peek, row-based data entry, also something that's in the work, but not ready to be demoed and released right yet. But again, this is us thinking about bulk operations, bulk data entry, etc. There might be a a list of households receiving the same intervention. There might be a list of children receiving the same vaccination. So being able to enter that same data for that whole list at a time will just expedite data entry time significantly. So again, very excited for this one and to work with our partners in the campaign space to get some early user feedback. So those were just some quick highlights. So thank you. And yeah, any questions on this? What is that? When it will be released? The maps one is like in a couple of weeks. The role based will happen probably in the fall sometime. Yeah, this year. Yeah. It's scared to make promises, but when the boss asks you, you answer. So yeah.
This is great, and to see this backlog of some of these features. We've been asking them for maybe 3 or 4 years for the disease surveillance, and we've seen, just like with malaria in the past, right? A project like this pushes and resets priorities. So it's, yeah, thank you for putting these onto the roadmap again. So
yeah,
really appreciate it.
Thank you.
So we didn't hear, by the way. Maybe the people Yes, we have them.
So the question for the people, I mean, was just giving good feedback that it's great again with these kind of projects where you're kind of delving a bit deeper into use case and figuring out some generic functionality that has maybe come up through other use cases like just malaria in general, etc. And it's nice that they can then be revisited and reprioritized, and yeah. There's
Thank you. We are from Madagascar. We have some problem in improving or in upgrading the DHIS2. We need all these functionalities, but lastly in 2023, we upgraded into 40.7, and our DHIS2 were not usable during 3 months. What is the problem? Thank you.
Yeah, it's hard to. Yeah, I was going to say it's hard to say exactly here, but we do have expert lounge. Is it tomorrow, the expert lounge? So okay, so expert lounge for upgrade and testing is on Thursday, and then there's also a session on upgrade and testing. Also Thursday? Yeah, Thursday is your upgrade and testing day. Then you get to talk to people who really work with helping countries figure out their upgrade issues.
Yes, thank you very much. I was wondering if the role-based data entry will be available for Android, because it's one of the things that would help us a lot in Uganda with our campaigns and individual level capture.
Initially, it's capture on web, so like computer and laptops. So we think with Android, you do have the issue of space, at least on the phone, maybe not on the tablet. So we have thought of it before, but this initial one, it will be like a role-based plugin in the Capture web app. Yeah. If there are no more questions, I think I will just be done for now, and then we can see if there's more questions at the end. But thank you for all the comments. I want to then hand it over to Ola Arinola from the UNICEF HQ, and again talk about how they work with countries on monitoring immunization and catch-up campaigns using DHIS2.
Is it working now? Let's talk a little bit loud. Hello, everyone. Can you hear me? Yeah. Did you say hardly? Not really?
This one.
Hello, can you hear me now? Do you not? Okay.
Yeah,
No, okay. So I think it's my voice then. Can you hear me now? I think I can even hear that it's quite loud. Right. Thank you. Hi, so my name is Olajumoke Arinola, and I work with UNICEF's Digital Health and Information Systems Unit. In the room is still Maria Muniz. She works with UNICEF as well, and there are other UNICEF colleagues that I don't really know their name. There are also other colleagues that would really like to join this conference, Christina, and some of the group at our units as well. Just acknowledging them in case they're online. So I'll be speaking about some of the work we did with University of Oslo, and then just thinking about how the big catch-up campaigns were monitored for immunization. So just a big background about our work at UNICEF. Our vision for digital health is that countries are able to adopt technology solutions that prioritize reaching the most marginalized children. And you see that across some of the kind of initiatives we support in supporting open source, digital public goods that can do this at scale, and that countries are able to build capacity on their own to do the work. So you would see things like GIS work, CRVS, mapping communities and health facilities and community health workers, microplanning, logistics management. So these are different pieces of work that we support. So basically anything really across the life of the child to supporting the mother, supporting the children would be things that we are interested in. Now, going to the juice of this conversation, which is the Big Catch-Up. So the Big Catch-Up is a global initiative that was launched in 2023 to close immunization gaps caused by the backsliding of coverage during the pandemic, and to then restore us back to global immunization levels and strengthen the immunization system so that catch-up activities become integral to immunization programs. So basically, children that were missed between the 2019 to 2022 bed cohort, in that bed cohort would be, eligible for a catch-up dose, and they would be at least, so far you are at least 5 years old, you are eligible for a catch-up dose. And to do that, catch-up in itself is not a new concept. The Big Catch-Up is the initiative. And countries would use different approaches to try to achieve this goal. So one of them is the periodic intensification of routine immunization, whereby you screen the children first to know, their status before you then vaccinate. And then there's the normal routine immunization, routine delivery. There's the supplementary immunization activities, missed opportunities. So really different, and integrating it into measles campaign, whichever campaigns, all of these, or the school work, and all of these are all part of the strategies that we see that countries are adopting. Now, for countries to then, for the implementation to go on, of course, they had to do some readiness assessments. So where they were defining the catch-up policy for the country, developing SOPs around it, because they are global guidance, but then it has to be contextualized to different countries' use case. And there's also adapting the data collection tools to include now children between 12 to 23 months, and then children 24 to 59 months were included in their, in the data collection tool. That is the tally sheets, the home-based records and things like that. Then, of course, that has to correspond with, updating the information system as well to capture this disaggregated vaccination data. So I think this is just really the repetition again of the last slide. Now, how did countries then, what was the reality of what they did? Based on the recommendation is for countries to try to adapt it within the systems that they're already using. So example, DHIS2 or their routine systems really, or, just use an open source tool, a tool that they already have experience with, and they can scale rapidly. What they did in reality, based on the reports that we saw, first of all, it shows that, I mean, there are different activities that are related to campaigns here. So, of course, there is the macro planning piece where they have to determine, prioritize, who to reach, where to reach, and things like this. So many of them used, of course, the national population estimates, DHIS2 WINIC estimates, I think they used. Many of them, some countries did zero-dose mapping, where they used DHIS2 tracker in, I believe, Mozambique. Ethiopia used ODK and Power BI for their zero-dose mapping pieces. Micro-planning, some people reported using, doing some GIS mapping work. Implementation, various tools were used across, of course, with DHIS2 as well. Some of them did individualized immunization registries. Supportive supervision was another big piece. Vaccine distribution was not really contextualized in the context of BCU. Some of them had gaps in reporting that. And then there's the household assessment piece as well. Now, for the DHIS2 work, for countries that leverage DHIS2 for this work, of course, for BCU target setting, many of them you reported using administrative data already collected in DHIS2 or WINIC estimate to, estimate the number of children, determine the areas to prioritize, and things like this. Madagascar was one of those countries. Zero-dose and under-immunized children mapping. Mozambique, like we said earlier, used the DHIS2 tracker for mapping of zero-dose children in selected districts. They didn't necessarily scale it across the country, but at least they were able to use it for that use case. Aggregate coverage monitoring was the popular one, which, where some countries used it for both campaign and non-campaign use cases, and then the electronic immunization registry. So there are a lot of missed opportunities like we would see. Now, in terms of why they used it or why they didn't use DHIS2 for the big catch-up, so what we saw from their report is that a lot of countries, not a lot, some countries started off the big catch-up work, but they were yet to customize their tool in time for the first rounds of the big catch-up. So that meant that some of them used Google Sheets, some people used ODK, any tool they perceived that in their sense that was easier to customize were some of the things they used initially for starting out the big catch-up work. And that then resulted in having data backlogs. The need to then integrate this data now into DHIS2. Why? Because they still want to have the data in DHIS2. And some of them want to make a complete shift from using the tools they had earlier decided on to DHIS2. So that meant that there was this backlog issue they had. And, so we had that in our hands. And then, of course, customizing the DHIS2, I mean, with all of the capacity we have in this room and in the, bigger room that we had in the morning, it's probably just maybe there's a gap between, the programs teams talking to the digital teams, or, the context differs across countries, which we can't really speak to, but sometimes there were just gaps in the time it takes for them to customize the tool for the implementation itself. The next thing was also we saw a lot of mid-implementation shifts where countries are trying to, in between the work, now decide, okay, now we don't want to use ODK again. We want to then use DHIS2, or we want to use DHIS2 now for routine monitoring of the catch-up indicators. So in line with that, it then meant that you have to then make the shift from the tool you have earlier prioritized into DHIS2. And then also there's also the infrastructure to support some of the earlier selected tools that they had wanted to use. So due to maybe server, funding, devices, so all of these were all contributing factors. And then also some countries had policies, and in the big catch-up policy in some countries is that they would continue to monitor catch-up beyond the big catch-up. So that meant that they then have to transition into the routine systems if they wanted it to do it long-term. And then of course, all of these mid-implementation shifts back to the previous one meant that they needed to do retrospective data entries into their DHIS2 system. We saw low-level integration attempts as well, where they're either using health workers or data clerks to try to do those integrations. And then the other thing is there was also data quality concerns across some of these countries. And the countries that successfully used DHIS2 for both the campaign activities and non-campaign-like activities, of course, had capacity to do it. They had local technical capacity to do it. They decided early on that they were going to use DHIS2 for the work. So that made planning easy. I think another thing is, I would say some of them had realistic reporting windows. Realistic reporting window, of course, in campaign mode, you want, more real-time data. But for some countries, they realized they'll probably not get the data that day. So some of them said, I think in Burundi, it was like 3 days reporting window where you have to report the campaign data, and then they reviewed it afterwards. So I think with that, it's made it easier for them to make those decisions and then, use the tool in campaign mode as well. And then they had regular data reviews, effective trainings, all of these were contributing factors. And the advantage of that is that they then have integrated immunization dashboards for both the campaigns and the routine immunization. Some of them just use the same dashboards, if they just integrated the data into the routine systems. And of course, they're investing in their local health workforce to manage these data models. So in terms of missed opportunities and the planned improvements, so in some of the reports we saw as well, some countries reported gaps in the after effect, the AEFI reporting, stock management reporting for BCU, digital microplanning. Some of them wanted to do it, but they couldn't do it. A number of countries still want to improve their dashboard views. And then, of course, we developed this DHIS2 BCU model. There are still gaps in the adaptation of the tool itself, even though it's readily available to be customized. And so planned improvements, we see that countries are trying to walk through. A number of countries are trying to improve their use case for zero-dose mapping, not necessarily with DHIS. So some of them want to use it, integrate it into their routine community systems. Some want to, just to improve the use case they had of it. But the point is that there's interest around that. Cameroon, for example, used ISO for the earlier iterations of their big catch-up. They are trying to integrate that into DHIS2. Tanzania, I think, used VIMS or plan to use VIMS, and they try to also link that to DHIS2. A number of countries are newly trying to use DHIS to support either the routine catch-up monitoring or trying to enhance their existing use case. And there are also a number of countries that are working through their data quality issues, both for the BCU and non-BCU use cases, and then just trying to strengthen their infrastructure broadly. So in line with all of those challenges, and then that we saw from last year, while there were a number of countries were trying to kick off the big catch-up work, UNICEF worked with University of Oslo to develop the BCU model, which is really an aggregate model already disaggregated, aligned with the BCU task force recommendations, that allows countries to be able to timely adapt this model for the big catch-up initiative. A number of countries that already adapted DHIS2 don't necessarily need it. They might use it to improve their use cases. But if it's a country that is trying to look at monitoring the catch-up indicators on a longer-term basis, then they would find it useful. So it has the customizable metadata, and it collects really all the indicators that you would think the behavioral and social determinants one, stock management, training, coverage. So it really has a rich indicator list. It has dashboards and analytics guidance for, there's also guidance available, I believe, online. There was the launch that we had where, the guidance was shared and things like that. And it just makes it easy for countries to be able to adapt the tool in case where they are looking to monitor these age groups. And of course, you can find out more. You can come to me. You can come to the colleagues at the University of Oslo as well if you are looking to adapt this. So why were we thinking that, okay, countries should, there's no real guidance around you have to use a specific tool. But why we think countries that are looking to implement the HIS2 for BCU are looking in the right direction is because, of course, they can monitor catch-up after the big catch-up, which many of them have indicated interest in doing that. So it just makes it easier for them to do that. And then they can maximize all of these investments that they are making in training, just the infrastructure around the HIS2 itself, the capabilities that continues to expand are things that they can leverage, and just makes also in the context of shrinking funds and things like this, it just makes it easier for them to maximize the investments, and then they can tap into the local capacity they have in this room and even in the countries as well, for both campaign and non-campaign use cases. They can continue to evolve their HMIS application, just now leverage what the program really needs. So some countries are very interested in maybe doing the zero dose mapping. Some are interested in another, parts based on the program adaptations that they have. Yeah, so that's that. And then looking ahead, we are seeing that really the capacity of countries to integrate systems there are still gaps in doing that, at least from some of the reports that we're seeing. So sometimes there's really no need to do the complex interoperability where the capacity is not there. So there might be, it might just be easier for them to integrate the same systems where the capacity, they have more capacity to do that. And then they continue to just build their workforce expertise, making sure that there's communication between the technical teams and the programs teams, allow them to innovate as much as possible. Not to say they can't use other systems, but use it in a way where they have the maturity to do that. And then, of course, just drive collaborations. So I think that brings my presentation to the end. Any questions?
Yeah, any questions over there? Hopefully that microphone works okay.
Hi. Yes. Okay. Thank you for this. This is fantastic. And one of the things that you point out here for the looking ahead, the integrating routine and campaign systems, what we saw a lot in Mozambique is from a supply chain perspective, they have stock for campaign and then a sub over here stock for the routine. But inevitably, if they're doing a campaign, they run into a 10-month-old kid, they're going to vaccinate whatever that kid needs. And so it's like from the stock perspective, it is so confusing to know what really is actually getting used. And I mean, coverage as well, but then also from stock. So I really appreciate the integration of the routine and campaign systems, because I do think with much effort as we collectively have done on all these big catch-up campaigns, it's still like this parallel thing, and we have to move towards this a more integrated, like vaccine is a vaccine is a vaccine, a baby is a baby. And so I think that will help from the supply perspective, then be able to justify all the vaccines that Gabby has purchased, that UNICEF is bringing in, that all countries are planning for. Because at this point, we don't really have visibility across the entire supply chain. We've got a parallel structure and everything is just a little bit fuzzy.
Thank you.
I guess it's not a question, it's more of a glad you're doing it and let's keep going on doing better.
Yeah, thank you very much. From Tanzania, actually working under HISP Tanzania. Yeah, as you said, we have seen also in Tanzania, they have implemented the big catch-up. So my question has been like, since we have seen the big catch-up being implemented as a separate, and then the objective was to track those who missed those during the COVID. So my question is that this initiative is for the how long? And after that how long ends, what the way forward? That will be discarded and they will be analyzed separately, because the implementation has been that you have the big catch-up and then you have the routine one. However, the same dose that are being tracked for both. Yeah.
I think that's just it. Right. Thank you so much. And I agree. For the stock management data, I think it would differ from country to country. So a lot of countries have made big investments in like their HMIS systems, and maybe just integrating with DHIS2 might be really difficult. So I think it's really a country to country basis, and depending on the maturity levels of the countries, I would say. I think about the big catch-up monitoring. So the big catch-up initiative, it's ending this year. The big catch-up itself is ending this year. However, catch-up monitoring in different countries, a number of countries are committing to monitor catch-up groups, even after the big catch-up initiative, right? So this big catch-up initiative is supposed to help them strengthen their systems to be able to continue to do that if they choose to. So it will really depend on the policies that different countries are making around monitoring catch-up indicators. Who is a catch-up target group, and how do we monitor the catch-up target group? Is this something we want to continue to do, after the big catch-up? And we are seeing, even from the big catch-up dashboard that is publicly available, actually, that a number of countries are beginning to commit to say they want to continue to monitor the catch-up groups, catch-up after the big catch-up. Right. So all of the funding they're getting at this point and all of the resources that are coming through at this point is supposed to help them strengthen their systems to be able to do that, even after the big catch-up. Right. So it is valid for some countries to continue to do that. Yeah. Thank you. So I think that's all.
I think unless there's any burning questions, we might move on to the next presenter. If that sounds good. Thank you so much. Now I want to hand it over to Ismail Koleleni, the director of HISP Tanzania, to talk about Somalia and the impact of electronic immunization registry for vaccination services. So, floor is yours.
Hello, good afternoon, everyone. I hope you can hear me. Kristen, you can hear me? Good. Yeah, so thank you all for being here. I'm going to be sharing a country use case implementation story from Somalia, as introduced by Karoline. My name is Ismail Koleleni from HISP Tanzania, and we have been working to support Somalia for the past 5 years, primarily DHIS2 and a couple of other health implementation activities in Somalia. And through that, we were privileged to support the implementation of electronic immunization registry in the country using DHIS2. And this work was or has been successful in very close collaboration with the government of Somalia, the Ministry of Health, together with our partners, WHO, as well as UNICEF. And good to see some big catch-up presentation earlier on, because it came a little bit later after we had already started working on this, but there's been very good synergies and connections in the country. So a little bit of history. As I said, we have been working and supporting Somalia. There were started exploring the use of DHIS2 in early on, since the beginning of 2016, 2017. But they formally adopted and implemented it in 2020 to 21. That's where it was nationally scaled up, but as the HMIS system, just like a growth and evolution that many countries go through. They started adopting DHIS2 as a routine health information management system. And 2 years later, as we all know, the classic DHIS2 implementation relies on paper-based and manual data collection at the health facility level. And through this, based on the paper, it involves a lot of manual data collections, right? And these are very common problems that leads into inefficiency of data, as well as not timely reporting and accurate data collection. So this has been kind of the biggest challenges that has actually influenced or called for even much more granular level data collection within the health facility, considering that Somalia has been going through massive transition. Of course, as we know, the background of the countries with conflict and wars happening, but it has not been very far in terms of adaptation of technologies. So, yeah, these are some of the challenges that were actually as a result or being very much well noticed in the as we are implementing DHIS2. And through that, I would say they have a monthly paper-based data collection systems, which is collected through DHIS2, which is focused on immunization and child services. But because it's a manual process, or it has been a manual process, it relies heavily on fragmented patient records, but also a lot of data losses, as well as massive missed in vaccinations, as you know, because of a lot of dynamics within the country, but it's also a community is moving a lot. So that results into you vaccinate a community today, and then they've already moved, they don't come back. And at the end of the day, a lot of mixed vaccinations. So this is where the government and the Ministry of Health thought that it would be very best to invest in a much more granular individual level tracking system that will be able to track and allow follow-up of individual children throughout the vaccination program. So we were very lucky with all the global DHIS2 work that has been happening. I'm sure we all know about a lot of work DHIS2, the University of Oslo HISP Center, together with the HISP community in general, in terms of adapting the standard DHIS2 toolkits. And this has really been trying to standardize some data collection from aggregate all the way to some individual tracker module. So that is where we introduced or took advantage of that to introduce an electronic immunization registry, which is based on purely DHIS2. And that started very quickly and very fast because of the existing DHIS2 toolkits. That was first, of course, from aggregate, but also the metadata packages that were available to kickstart the process. So that supports, of course, both the web-based, but also the online and offline data entry through the web-based, but also the Android, which was primarily the target focus, is configuring some Android devices that will allow portable data collection within the health facility level. But also what was very, very crucial and very important, because the ministry was very clear in terms of they don't want to duplicate the effort. So is being able to automatically aggregate and provide the monthly reports, which were, again, collected using the paper-based. So that automation from the tracker individual level data to monthly aggregation form has been one of the biggest factor that has really helped through the process. And through that, of course, a lot of program indicators being written or configured to be able to support that process. And we are very happy to see some of the new features that has really helped in terms of aggregating and summarizing that, because yeah, these kind of use cases have been really struggling out of that, because you have to create so many duplicate program indicators. And with these new features, I think after the country has upgraded, and then we'll see much more better clean metadata configuration as a result of that. But this, I mean, nevertheless, that has been very helpful to kind of show the connection from tracker level data to aggregate monthly reporting. But also, I mean, the coverage and other indicators throughout the immunization journey, you are able to track throughout the process from the first immunization all the way through other stages up until the child is reached the 5-year-old. And thanks to the, of course, existing guidelines, but also the metadata, and we have also been building some local contextual configuration based on that. Now, what was the adaptation process? I think more or less the very same processes that we use to deploy any digital solution. So it started with a phased approach, and we, together with the partners and the government, implemented this in 14 health facilities in one of the biggest region in Somalia called Banadil, which Mogadishu is part of that. So these 14 facilities were kind of the pilot studies to kind of test and see and get the feedback. And this has been happening for the past 8 to 9 months now. I think, since late October. So yeah, so it's about 8 months, but also the follow-up mechanisms. And this has been very, very crucial, because we managed to integrate DHIS2 with the SMS gateway, local SMS gateway, and set up the individual reminders, so that when they missed, and then you get the phone number of all the mothers or whoever the caregiver is, to remind them whenever they miss a vaccination or whenever the vaccination is approaching. And this has been very, very helpful in terms of, for these 14 facilities, one of the biggest feedback is they see a lot of follow-up happening without having to, manually go to the households and the families. So this has been very helpful in terms of if they miss the doses, but also sending them reminders in advance to make sure that they don't even miss that. And thanks to the SMS functionalities, as well as the notifications within DHIS2 functionality. But also vaccination tracking, this to allow the healthcare worker to update and manage. I think these are schedulings even within themselves. They know what are the plans, who is expected to come, and even to, manage their stocks within the health facility. And finally, but not least, is being able to, get to use the data. So we used to allow or use the existing, but also enhanced dashboard and other analytics, both from the tracker side, but also most importantly from the all the existing useful analytics that DHIS2 provides, from dashboards to exciting analytics features to help them, especially the managers, use the data and see the data and make some decisions, follow up, and intervene whenever it's required. So this is one of the sample, as you can see, of a routine weekly report that they used to provide. This was used to be manually written, but thanks to DHIS2, most of the information that goes to this report are now automatically generated from DHIS2, and they're able to disseminate the results out of it throughout all the stakeholders, but also take necessary action whenever they're needed. Yeah, so these are some of the outcomes out of that process, or out of that 6 months of piloting and closely monitoring these 14 health facilities that had adapted this this immunization registry so far. The first one, which is based on a feedback that has come from the actual users from the health facilities, they are now able to, because now they're using a digital system, so they're able to reduce the amount of errors they can make because it's not manually entering the data anymore. But also it has given much more time for them to actually focus on service delivery instead of managing papers and data collection. So ultimately that the feeling is it has really improved the service delivery and immunization. But another result out of that is, of course, efficient data management across the board from the health facility level, because they are not managing things manually now. It's primarily a digital level, but reduce also the burden at the district level, which is very much understaffed, and they have a lot of priorities, and all the way up to the program management at the central level within the states as well as the national level. But also data integrity, which is one of the key and the biggest goal is to, by now, because they are shifting from digital record keeping, it has really improved the accuracy of the data, accessibility, and even reducing the risk of information lost. But ultimately, out of these 14 facilities that deployed between 2023, before the implementation of EIR, and 2024, you can clearly see that the vaccine dropout rate improved or decreased by almost 1%. And this is just from 14 health facilities of deployment. Now you can imagine that if you manage to scale up this for the entire country, how much impact that can bring within the some of these vaccine dropouts. I mean, we can't claim that this is all done by only DHIS2. Of course, there are a lot of other factors. But yeah, I think using the systems and the digital is also helping improve the efficiency and as well as showing even this impact in terms of how much visibility of the data you can get. But also the automated SMS reminders that is sent, it has really significantly reduced the missed appointment and improve the adherence to vaccine. Yeah, so maybe before I conclude, some of key things that are currently happening as we are speaking is actually now they are already moving into scaling up to other states. As we know, Somalia is a federal government system, so the scale-up process is a bit administrative. You have to build capacity within the states and then use that cascade down. But they already plan, and the government, together with the partners, had already secured resources to scale up. So there is a scale up to other states and even more facilities to adapt the immunization registry as we are speaking. So a lot of trainings. Of course, that doesn't have to involve us as HISP Tanzania as the experts, because we already build a lot of capacity within the national team. So they are the ones who are coordinating and dealing that and doing the implementation. But also there are plans to integrate this with the stock management. This is also something that quite came up. Now, I mean, there are some data already that they are reporting within the tracker, but there is also a parallel plan to implement a stock management system, which ultimately will be integrating to this. And also the yeah, and also another big thing is enhancements of analytics features. That again, thanks to some of the new exciting features, I think there is a lot of opportunities and potential to enhance the existing dashboards to be able to support and even give much more information out of this immunization tracker. So that's again building on successful implementation. They plan to scale up, as I mentioned. That is already happening, but also being able to reduce the manually data collection as much as possible through integrations with other systems and other digital innovations. So thank you so much for listening, and I'll be happy to hear any comments or questions.
Yeah, any questions? Oh, some up there. Great. And also, have there been any on the Zoom? Okay, great. Yeah, a couple there.
Yeah, thank you so much for your presentation. This is Yasser from MOH Syria. You mentioned that there is a continued population movement. So the children, the child that was enrolled in this vaccination center can be for the next appointment can be in another area. So how you managed it, having a unique ID or so? Just for this question. Thank you.
Thank you. My name is George Munya from UNICEF headquarters. We are doing a lot of work in Somalia, so this is really promising, and we are absolutely right. I mean, data situation in Somalia for immunization has been quite difficult, and those who follow closely, the UNIC estimate has been flat for 12 years. So this is really a very good step. But similar to the question raised, in terms of when you talk about the impact of this initiative on dropout, you are looking at only 12 health facilities. So that in Somalia, like many other countries, a child is free to receive vaccination anywhere, and combine that with the movement. It means that I can receive my first dose within the 12 facilities, but my second and third dose is somewhere else. So that will create artificially low dropout. So I don't know, maybe because of the SMS, was there a way to track whether the case you are identifying as dropout case, they've received the service elsewhere? That is something, and I would definitely like to connect after this to see how this can connect with our work. Thank you.
Yeah, thank you so much, colleague from Syria as well as UNICEF. Yeah, in terms of tracking, again, if you scale up the system, we do believe that there's going to be a lot of findings and even much more outcome out of it. But at the moment, I think you rightfully said, so now with EAR, every child get a unique identifier that is printed on the child card, which is based on from the EAR, and they use that to kind of go throughout whenever they go get vaccination services. So that means that you get to receive the service anywhere, but also because the data is centralized, that information is pretty much recorded. But that only happens if, considering now it's not a nationally scaled system, so this system is not yet used everywhere. So that only happens if they only go and get a service where they use the same system. Otherwise, that data will end up again in the paper, which brings another level of complication. So I think these are some of the issues that usually comes up in any implementation, but technically, ideally, that's how it's supposed to work, where with unique identification, which is automatically generated from the system, we'll be able to help track around. But another crucial thing is, again, this SMS reminder thing has been very, very much impactful, because even if they go away or not, because to the big extent, this has been implemented in Banadir, which is in town areas. So normally people don't move as much within. In the remote areas, that's where it's a, what do you call this, communities that move? Nomadic, yes. In the rural areas, they usually move a lot, but in urban, the movement, yes, it's they can move around, but not much within the same city. So that doesn't bring massive impact. But yes, I think the more the system is going to be deployed in the rural areas, and then we'll find out more. But from the system design as well as implementation perspective, we do hope that with this unique identifier as well as the SMS reminders should be able to help us or help them a lot in terms of reminding them, because most of the time also they don't even know that, you know, I'm supposed to go and get a follow-up vaccination or a second dose or something like that. So and from testimony from the healthcare workers, they see a lot of change out of this SMS reminders. So yeah, I think that is what I can say. From a colleague from UNICEF, yes, the dropout issue, we were even debating a lot in terms of putting that point there from our team, because it has a lot of questions. And again, it depends on what you're looking at it programmatically as well as what is happening on the ground. And yes, so it's very hard to measure, but clearly that's what we see. And we do believe that there is an element of impact in terms of reducing that. How much, to what exact? It's hard to tell because it's still a relatively small scale. But what we ultimately end up seeing is, yeah, it's a big impact just the moment you see this data there, you know, and drives this conversation. Because out of this type of conversation, is it right? Is it wrong? Is it direct? And then this is where even the program managers are able to intervene more and take much more action. And ultimately, that's even going to drive up even much more lower dropouts rates. So yeah, I think I'll be very happy to connect and maybe discuss this further. And we do believe with the programmatic technical expertise, we should be able to guide and improve the system even further moving forward.
Thank you. Great presentation. In terms of national scales, are there any plans to connect the electronic child registry with the national birth register systems? And if you do so, are plans to contribute back to the community so other countries can leverage on the developments?
Yeah, so I can't speak about Somalia because it's still on a very early stages, but from experience, the birth registration is usually not the Minister of Health. It's a different government department. But usually that is usually the next big question. From our experience in Tanzania and many other countries that we've been doing the similar work is there's usually a very close call in terms of integration so that they also are able to get the right data, but also even issuing birth certificates and other things. So nothing yet from Somalia because they still want to establish and see the direct result out of this work so far. But we do believe that that's a conversation that should be happening soon. I'm not even sure what system they're using on that side. So it's a good question, but I don't have the right answers yet. But yeah, maybe from other countries, I think we have a lot of experience with that, and we are able to happily to discuss and share much more experience from other countries.
So I think maybe last question, and then we're going to go out and do some networking.
Thank you. Mary Bomi from Chai Cambodia. Thank you very much for the presentation. I was wondering what are the difficulties that you've encountered in the project implementation and like use, and any challenges you foresee moving forward in more the rollout and more patients and more data.
Yeah, that's a good question. I think we can write a book about that. Yeah, I think I'll try and summarize just some few quick ones in terms of difficulties. Again, Somalia is not an easy country. I see a colleague from UNICEF is smiling. Yeah, because just the nature of the country, the political dynamics and other things, it's not an easy country to primarily do anything. But the good thing about all this is there's very big aspirations from the government, so that kind of helps in terms of driving things and creating that ambitions to do things and showing results. There are a couple of challenges. mostly around logistics and just routine things that you do expect things to happen smoothly because of but due to it's a conflict country, the security issues are very are complicated, so that kind of slowed things down a bit, and sometimes things which are usually straightforward, they will take longer than what you anticipate. So that is one. So even how you do trainings, who do you train? There are certain areas that you can't reach, and then you have to even with support. With this, even on the selection of the facility, they had to strategically select which sites to, pilot this areas that we could actually even have access to the experts, because there are some areas that even the government people themselves, they are not able to reach out to. So those are, some of the type of challenges that are there. But also another challenge is related to around capacity and knowledge. Again, it's a relatively upcoming country in terms of capacity. It's an advantage in a way because you get a lot of young, energetic teams, but there is also very high level of transitioning of staff. So that kind of you build capacity to this team today, and then in the next year, everyone is gone, and then you get a totally new people. So that transitioning and of staff has been a bit of a challenge, and this is across the board, from the national level, government level, all the way down to health facility level. So that is also has been a challenge. Another challenge, of course, is technical challenges. It's always not a very straightforward thing to do such a thing in DHIS2, but luckily, again, as HISP Tanzania, jointly with the global HISP team, there's always a lot of lessons to be learned. You know how to navigate. I just mentioned earlier on around program indicators and building up this tracker to aggregation. It's not a very straightforward process. It has never been, but hopefully with these new features, it should be. But yeah, so those are always some of the technical challenges that we've been experiencing. Was that the last one?
I think so, just because we're a bit over time. People probably want to go out and see the posters and the sessions. So really want to thank again the presenters and all the great questions. And thanks to Gavi and UNICEF and Chai and the Gates Foundation for their collaboration and support on this work. So thanks all, and see you out there.
We have the QR code here on the screen.